My name is Sanjit Jolly. I'm an interventional cardiologist and professor of medicine at McMaster University in Hamilton, Canada. I'm going to take you back to the spring of 2020. And we were a group of cardiology researchers who were hearing stories from Italy and the catastrophe that was happening. Patients were getting crash intubation, ventilation, they're running out of ventilators, and patients were dying of COVID-19. All our cardiology trials had stopped, and we pivoted to do a COVID-19 treatment trial. And we actually did a series of trials. An outpatient trial trying to reduce the load on hospitals, try to prevent hospital admission and death, and an inpatient trial to try to reduce mechanical ventilation, death, high flow oxygen, because we knew that those things were actually very, very important. And we understood from what we knew then that the pathophysiology there were two important mechanisms of COVID-19. One was the inflammation. The inflammation was very, very important. And second, thrombosis. Most patients who were dying were having microvascular thrombosis in many of their organs. So we designed a trial to target those specific mechanisms. So the outpatient trial, we tested two therapies. It was a randomized trial where there were two randomizations, about 4,000 patients, aspirin versus control to treat thrombosis, and colchicine versus control to treat inflammation. And what we found for the primary outcome for colchicine, which was hospitalization or death, there was absolutely no effect for colchicine compared to control. And for aspirin, when we looked at thrombosis as well as hospitalization or death, there was no significant effect with aspirin. And so it's really clear that, that both these therapies should not be used for the treatment of COVID-19 in outpatients. In the inpatient arm, I think it's important to note that most of these patients were hospitalized but not in the intensive care. 80% were on oxygen. Again, we targeted the same two mechanisms. For inflammation, we used a higher dose of colchicine, a loading dose that had been previously known to reduce IL-6 acutely, as well as maintenance dose for 28 days. And then the second randomization was different. It was a combination of rivaroxaban, 2.5 milligrams twice daily, as well as low-dose aspirin versus control. We randomized 2,500 patients. And what we found was for the primary outcome of need for high flow oxygen, mechanical ventilation, or death, there was no difference between the colchicine arm and the no colchicine arm. And when you looked at mortality, about a fifth of patients died in the trial. So mortality is still very high, but colchicine did reduce it. We looked at aspirin and rivaroxaban. In fact, again, the primary outcome of major thrombosis, death, mechanical ventilation, or high flow oxygen was not different. And mortality was not different. And so again, despite a lot of the hype around anticoagulation, we did not find a benefit from aspirin and rivaroxaban together. To put this research into context, we actually did an updated meta-analysis. And when you look at all the available trials of colchicine, and there were some trials suggesting potential benefit, it's completely neutral for mortality. The story is a little bit different with anticoagulation. When you intensify anticoagulation, you do reduce venous thromboembolism by about 40%. But that reduction in venous thromboembolism doesn't translate into a reduction in mortality, but it also increases bleeding. So it's really this interplay. I think the conclusion is that we should not be using colchicine in hospitalized patients with COVID-19. And aspirin and rivaroxaban were not beneficial, and really need to think about the risk versus balance with regards to intensifying anticoagulation. Yeah, and I think the meta-analysis really puts it into context. We had hoped, there were signals of benefit in the COVID trial and the Corona trial in outpatients, that maybe colchicine was an inexpensive way and widely available way to improve outcomes. But that wasn't the case, and the meta-analysis now clearly shows that it doesn't work. I think it's really important for we really seen the event rates drop over time. So certainly these variants are less have less morbidity and mortality associated with them. But when patients get hospitalized, they're still very sick. So we really need to focus on therapies that reduce mortality and that are really widely available to the entire world, not just Western high-income countries. So I think we still need to search for therapies. Steroids was probably one of the most important innovations in the treatment of COVID-19, and we need to find further therapies that can reduce mortality and the need for mechanical ventilation in COVID-19.